Hello, I am Dr. N.S. Mani, and this is the second part of the concept bridge in pathology. You can see similar sessions in my channel youtube.com/acpgmet. You can get the links from the facebook.com/acpgmet. Similar sessions are also available regarding the entrance oriented MCQ type questions and answers in youtube.com/acpgmet. Today we will be dealing with the cell injury, adaptation and cell death. The reversible injury. Reversible injury is the ability to heal without permanent damage. Cells can adapt to physiologic stress. Cells adapt by changing number, size or differentiation. Hyperplasia is an increase in number of cells. Hypertrophy is an increase in cell size. Atrophy is a decrease in cell size. Metaplasia is an alteration of the cell differentiation. Intracellular accumulations are an altered metabolism. Hyperplasia can be physiologic or pathologic. Hormones may drive hyperplasia, like pregnant uterus or lactating breast. Compensatory hyperplasia may occur with the tissue damage, like liver regeneration after partial hepatectomy or wound repair. Initiation of cell proliferation includes induction of transcription factors and cell cycle proteins. Pathologic hyperplasia is a risk factor for neoplasia and is usually due to excessive hormonal stimulation, like polycystic ovary disease leading to excessive estrogen production or the effects of growth factors. Hypertrophy is an increase in the size of the cell due to the synthesis of structural components rather than cellular swelling. It is usually a physiologic process due to increased functional demands placed on the cell, like hypertrophy of striated muscles from weightlifting or cardiac myocyte hypertrophy secondary to systemic hypertension. There is expression of embryonic genes in hypertrophic cells, which appears to be triggered by both mechanical and trophic factors like structure receptors and growth factors. The process can become pathologic when the limit of hypertrophy is exceeded and the cells can no longer compensate for the increased burden, like congestive cardiac failure. Atrophy is the reduction of cell size or organ size. Physiologic atrophy occurs during fetal development, like regression of the notochord, and throughout life, like muscle. Common cause of atrophy of muscles include decreased workload or denervation, like paralysis, diminished blood supply, like atherosclerosis, inadequate nutrition, like marasmus and muscle wasting, loss of hormone stimulation, like menopause. Aging, building up of cellular waste and DNA damage. Compression, like organ compression by expanding tumor. The mechanism is incompletely understood, but it is thought to be an imbalance of synthesis and degradation. Increased number of autophagic vacuoles is seen. Metaplasia. Metaplasia is differentiation from one mature cell type to another, like squamous metaplasia of glandular respiratory epithelium. Metaplasia is an adaptive response to a hostile environment. Metaplasia is usually a change from glandular mucosa to keratin-rich squamous mucosa, like squamous metaplasia of ciliated respiratory mucosa because of smoking, or mitochondria-rich oncocytic cells like apocrine change in breast, Hurthel change in thyroid, oncocyte change in salivary gland. Metaplasia from squamous to glandular mucosa is unusual but is a common consequence of chronic reflux esophagitis, which causes heartburn, called the Barrett esophagus. Mechanism is thought to arise from reprogramming of stem cells like or the reserve cells from the basal layer. like squamous metaplasia, the cervical transformation zone. Metaplasia increases the patient's risk for carcinoma, like lung cancer from smoking, esophageal cancer from the reflux. Intracellular accumulation represent metabolic derangement. Endogenous substances may accumulate. For example, steatosis, fatty change develops in the liver because of the metabolic changes associated with toxins like ethanol and certain drugs, diabetes mellitus, obesity, and pregnancy. Atherosclerosis, cholesterol deposition and intimal damage develops because of endothelial damage and elevated cholesterol level. Immunoglobulin produced in excess in chronically active plasma cells produce round cell Russell bodies. Lipofusion is brown pigment derived from lipid peroxidation and is commonly seen in aged organs. Melanin is a dark brown pigment made in skin, hair and eye, iris and choroid layer. In skin, pigment production increases with UV exposure, which protects the underlying layers from damage. Hemosiderin is a granular brown pigment composed of ferric oxide resulting from breakdown of hemoglobin, which may be sign of hemolysis or disturbed ion metabolism like hemochromatosis. Clinical correlation of these pathological descriptions. The problem with aging, cellular aging is currently an irreversible injury. It is thought to be programmed senescence and accumulated damage. Telomeric shortening seems to play a key role in senescence. Replication of the chromosome caps appears to be incomplete with each cell division, causing shortening and final maturation. Cellular damage is caused by reactive oxygen species, which are usually a consequence of radiation and toxins. Neoplastic cells express telomerase that lengthens chromosome caps, thereby immortalizing the tumor clone. Irreversible injury. Cell death is irreversible and present as necrosis or apoptosis. Cell death has a long list of causes, but basically it is a consequence of cytoplasmic damage, DNA damage, or both. Necrosis is fundamentally a cytoplasmic driven process. It's a pathologic process resulting from the swelling and denaturation of the cell, hypoxia leading to depleted ATP reserves, and opening of ion channels leading to cellular swelling and enzyme release from digestive lysozymes. Release of cellular breakdown products and cytokines incites an inflammatory reaction and wound healing. Distinguishing necrosis from apoptosis. In necrosis, there is cellular swelling, nuclear swelling and lysis, death of many cells, lysosome breakdown, inflammation, calcification, cessation of protein synthesis, and there is no energy needed. Whereas in apoptosis, there is cellular shrinkage, chromatin condensation and fragmentation called apoptotic bodies. There is death of single cells, lysosomes are intact, there is no inflammation, there is no calcification. Apoptosis requires protein synthesis and it is energy dependent. There is a well described and reproducible temporal sequence observed after necrotic cell death like myocardial infarction. Hours after the insult, there are no clear features. One day after, there are microscopic changes like waviness. 1 to 3 days after, there is gross necrosis and microscopic infiltration by neutrophils. 3 to 7 days after, there is disintegration of the dead tissue and accumulation of macrophages. 1 to 2 weeks after, there is granulation tissue, fibroblast and blood vessel proliferation. 2 to 8 weeks after, there is increasing collagen deposition. 2 months after, there is a dense fibrous scar. Liquefactive necrosis affects soft organs like brain infarction from stroke. Hemorrhagic necrosis affects highly vascular organs like pulmonary infarction from embolism. Caseous necrosis is the cheesy white center of granuloma like in tuberculosis. Fat necrosis in dead adipose tissue, example trauma to breast or enzyme release in pancreatitis. Areas of necrosis may calcify. Breast microcalcification associated with necrosis from fibrocystic change or carcinoma. Apoptosis is fundamentally a DNA-driven process. It is programmed cell death without an inflammatory response. There are two primary pathways. Extrinsic pathway is through the death receptors, members of tumor necrosis factor TNF family, which deliver the apoptotic signal. Intrinsic pathway works by increasing mitochondrial permeability and releasing pro-apoptotic molecules into the cytoplasm, like BCL2. Both primary pathways lead to the execution phase, which uses specific proteases like caspase to shrink and break down the cell. Classic examples of apoptosis include cells deprived of growth factors trigger apoptosis, radiation induces DNA damage and apoptosis. Clinical correlation: P53 and tumor suppressor genes. P53 is a tumor suppressor gene because it induces apoptosis in cells with DNA damage. That is the source of mutation and uncontrolled cell growth. As people age, there is a progressive risk that these tumor suppressor genes will mutate, leading to uncontrolled mutation and cancer. Inflammation and repair. Acute inflammation. There is a rapid response to offending stimuli like trauma, necrosis, infection, toxins, and that recurs within minutes and usually only lasts a few days. The cardinal features of acute inflammation are rubor, tumor, calor, dolor, and punctualiza. Rubor is redness from vasodilatation, tumor is swelling from permeability and edema, calor is heat from fever caused by necrosis and cytokines, dolor is pain from prostaglandin, and punctualiza is loss of function. Process begins with endothelial cell activation, vasodilation and increased permeability stimulated by nitric oxide, endothelial cells, histamine from mast cells, and bradykinin from plasma. They increase overall blood flow but slows the speed of blood across the endothelial surface. Integrins on leukocyte attached to endothelial selectins, endothelial intravascular adhesion molecule 1 ICAM1 and vascular cell adhesion molecule VCAM guide leukocyte through this barrier into the surrounding tissue. This process is called diapedesis. Chemotaxis is a cellular locomotion across a chemical gradient. Exogenous stimuli attract neutrophils like bacterial antigen attract leukocyte. Endogenous stimuli attract and activate neutrophils like C5a complement, leukotriene B4, cytokine IL-1 and TNF. Acute inflammation can be oxidative, causing serous, or fibrinous, causing extravasation, and suppurative, which is neutrophil pus. When neutrophils cannot neutralize the causative agent, or if there is tissue necrosis, a chronic inflammatory reaction develops. Complementary pathway. The complement system is composed of precursor proteins and their active cleavage products that are predominantly found in the plasma. The classic pathway is triggered by C1 binding an antigen antibody complex. C1 binding an antigen antibody complex. That is the triggering of classic pathway, and it culminates in C3a and then C5a activation. The endothelial response to injury is shown in this picture. Endothelial cells are the orchestrators of the acute phase response to tissue injury. Within minutes, histamine, nitric oxide, leukotrienes are released. Within hours, leukotriene 1, tumor necrosis factor, gamma interferon are released. Indirect injury, reactive oxygen species, proteolytic enzymes, and C-reactive protein also act. Direct injury, trauma, burns, and other infection. These are the four factors, and they cause the endothelial cell response to injury, and finally tissue injury occurs. Now coming back to the alternative pathway. The alternative pathway activates C3a and then C5a via bacterial surface polysaccharide like lipopolysaccharide LPS. So in this picture I am showing the classic pathway. Antigen antibody C1, C4 plus C2, produces C4B2B. Then along with C3 produces C3A. Then the C4B2B3B. Then with the C5 becomes C5A and C5B. The anaphylotoxins are the C3A and the C5A. From the C5 you get the C5B. 6, 7, 8, 9, C6, 7, 8, 9, they constitute the C5B69 membrane attack complex. Then the alternate pathway toxins C3 factor BD, C3B, BD, BB, properdin with the C3 constitutes the C3B, BB3B. With C5 produces C5A, or from C3 it can go to C3A. Complement is predominantly circulating plasma proteins that marshal a response to antigen-antibody complex, classic pathway, or with alternate pathway, which is activated by bacterial toxins like LPS, which I told you before, or venom. Either way, the result is production of anaphylaxis toxins C3A and C5A and the membrane attached complex. The clinical correlation of the complement system in health and disease. Escherichia coli infection leads to LPS release and C3 activation. Bacteria are also coated by C3b opsonization, which binds the CR3 receptor on neutrophils, activating them for phagocytosis. Phagosomes containing E. coli fuse with the lysosomal granules, leading to reactive oxygen species burst O2, H2O2 and OH. Defects in C3 lead to fatal infections if untreated. Defects in C2 and C4 are associated with autoimmune disease like lupus, and defects in membrane attack complex leads to Neisseria infection, that is meningococcal meningitis. Chronic inflammation. Chronic inflammation is a prolonged response, at least weeks in duration, to stimuli which may be de novo. Many serious human diseases are related to chronic inflammation. Primary causes include the following: exposure to toxin like cholesterol and atherosclerosis, foreign body like asbestosis, silica and suture material, autoimmunity like SLE and rheumatoid arthritis, persistent infections like tuberculosis, fungus and virus. Chronic inflammation is characterized by mononuclear cell infiltration like macrophage, lymphocyte, plasma cells and histiocyte. Architectural changes occur like gland dropout and inflammatory bowel disease, and also fibrosis occur. Macrophages are the demolition crew of the body. C5A recruits monocytes from the bloodstream, activates them into macrophages. Macrophages also release a number of cytokines and proteases that lead to tissue destruction. Lymphocytes, B cells and T cells are attracted to the site by integrins and chemokines. B cells proliferate in reactive germinal centers and eventually mature into plasma cells to make polyclonal antibodies. There is a kappa and lambda light chains. T cells produce cytokines including gamma interferon IFN, which is a major activator of macrophages. Granulation tissue is a well-orchestrated process to clean up the dead tissue and replace the area with fibrous connective tissue that will provide a maximum strength. Pre-existing capillaries in surrounding and damaged tissue form new capillaries in the damaged area. Basic fibroblast growth factor BFGF stimulates angiogenesis and fibroblast proliferation. Tumor growth factor stimulates fibroblast and collagen synthesis. Vitamin C and zinc are also needed for wound healing. Ironically, although strong, the resulting scar is non-functional and may lead to significant clinical sequelae like myocardial scar decreases heart contractility, leading to congestive cardiac failure. Scars may also be hypertrophic, called keloid. Granulomatous inflammation. Granulomatous inflammation is a specific type of chronic inflammatory response characterized by nodules of activated macrophages or histiocytes with a plump red epithelioid morphology and multinucleated giant cells which are fused histiocytes. Foreign body granulomas are most common, arise around inert foreign material like a suture or silica. Non-caseating granulomas may also be seen in autoimmune disease like sarcoid and Hodgkin's lymphoma. Caseating granulomas are necrotic in the center and are almost always due to infections like tuberculosis and fungi. Organisms may be identified by culture, that is microbiology. In tissue sections, organisms may be identified by special staining like a Phyte stain for acid-fast bacteria, Gomori methenamine silver GMS stain for fungi. Molecular testing like a polymerase chain reaction PCR is becoming more widely used to detect subtle infections. Clinical problems based on the previous discussions are following. Please take a paper, and this is an MCQ type of questions. Answer the questions and then check for the correct answer. Which of the following statements regarding smoking is correct? It is a stimulant that increases the ciliary action of the respiratory epithelial lining, or that inhibits the ciliary actions of the respiratory lining and contributes to obstructive pulmonary disease, or it causes lung cancer but not bladder cancer. Option D is it contains particulate matter and irritants, the most dangerous being carbon monoxide. Option E, it is recommended for pregnant women. Which option is correct? The answer is B. Smoking inhibits mucociliary actions of the respiratory epithelial lining, causing mucus to accumulate in airway and causing symptoms of chronic bronchitis. Although smoking contains nicotine and is a stimulant, it does not stimulate clearance of mucus secretion. Although smoking is responsible for a large number of lung cancer, it also causes bladder cancer, oral cancer, and is a risk factor for many other cancer. Smoking leads to carbon monoxide accumulation, which inhibits red blood cell oxygenation. Smoking is dangerous for the baby in a pregnant woman. Ethanol is metabolized by alcohol dehydrogenase into acetaldehyde, alcohol dehydrogenase into acetate, aldehyde dehydrogenase into acetaldehyde, aldehyde dehydrogenase into acetate. None of the above. Which option is correct? The answer is A. Ethanol is metabolized in the liver to acetaldehyde by alcohol dehydrogenase. The liver is the primary route of elimination. Acetaldehyde is then converted to acetic acid by aldehyde dehydrogenase. The polymorphism associated with an increased sensitivity to ethanol is in which gene? Aldehyde dehydrogenase, acetate, cytochrome P450, alcohol dehydrogenase. None of the above. Which option is correct? The answer is A. Approximately 50% of the Asian population has genetic polymorphism in aldehyde dehydrogenase that affects alcohol metabolism. A 19-year-old woman was admitted to the hospital after ingesting a full bottle of acetaminophen. Laboratory tests revealed markedly elevated liver enzyme. What metabolite contributed to her now life-threatening liver damage? Depletion of cytochrome P450 enzyme system. Option B, glucuronide conjugate. Option C, an acetyl P-benzoquinone. Option D, sulfate conjugate. Option E, N-acetylcysteine. The answer is C. Acetaminophen is metabolized in the liver, where its metabolite include inactive sulfate and glucuronide conjugate, which are eventually excreted by the kidney. Only a small amount is metabolized via the hepatic cytochrome P450 enzyme system, that is CYP2E1 and CYP1A2 isoenzymes, resulting in an alkylating metabolite N-acetyl-P-benzoquinone, abbreviated as NAPQ1. At usual dose, the toxic metabolite NAPQ1 is quickly detoxified by combining irreversibly with the sulfhydryl groups of glutathione to produce a non-toxic conjugate that is excreted by the kidney. NAC, N-acetylcysteine, is an antidote used as within 8 to 10 hours of acetaminophen overdose. Acetaminophen intoxication specifically causes diffuse liver necrosis, periportal liver necrosis, lobular necrosis, sundry lobular necrosis, and none of the above. Answer is D. Acetaminophen intoxication produces gross nutmeg pattern in the liver. Diagnostic of sundry lobular necrosis. Although there can be diffuse necrosis in some fulminant case of acetaminophen intoxication, most cases show sundry lobular necrosis. The necrosis is centered around central vein and is not confined to only the lobules. Periportal hemorrhage and necrosis are seen in women with eclampsia. The sixth question, some of the clinical manifestations of organ of phosphorus poisoning include the following: lacrimation, salivation, defecation; lacrimation, dry mouth and defecation; emesis, urinary retention, constipation; salivation, urination, dry eye; salivation, emesis, constipation. Which option is true? Answer is A. Organophosphate causes irreversible inhibition of cholinesterase, causing accumulation of acetylcholine, leading to bradycardia and the massive runs. The effects may be recalled as sludge syndrome, salivation, lacrimation, urination, defecation, GAT distressant, emesis, SLUDGE. The seventh question, reversible injury encompasses metaplasia, hypertrophy, atrophy and fibrosis, hyperplasia, hypertrophy and necrosis, hyperplasia, hypertrophy and apoptosis, hyperplasia, metaplasia, hypertrophy, atrophy and necrosis, hyperplasia, hypertrophy, atrophy and metaplasia. Which of these are reversible? Answer is E. Reversible changes include hyperplasia, hypertrophy, metaplasia and atrophy, fatty metamorphosis. Reversible injury can best be thought of in terms changes that cannot be reversed, such as fibrosis, cirrhosis of the liver, fibrosis replacing myocardial infarction, necrosis of apoptosis, which are dead tissues. The eighth question, difference between the classic and alternate complement pathway is: option A, alternate pathway needs antibody; option B, classic pathway needs antibody; C, the classic pathway needs C5; option D, alternate pathway needs C5; option E, the classic pathway needs factor B and D. Which option is right? The answer is B. The main difference between the classic and alternate pathway is that the classic pathway requires C1 activation by antibody complex with antigen. Alternate pathway does not require an antibody, instead uses microbial surface antigen. Ninth question, during the acute inflammatory process, integrins attach to receptors on neighboring leukocyte molecules within lipoxygenase pathway, antigens on leukocyte, selectins on endothelial cell, cytokines like IL-8, interleukin 8. Which option is right? The answer is D. Acute inflammation is a vascular process. Leukocytes start to tumble across the endothelium and transiently adhere. Sialyl-Lewis X modified glycoprotein and integrins are present on the surface of the leukocyte, attaching to the P-selectin and D-selectin on endothelial cell. Products of lipoxygenase pathway are involved in chemotaxis. Which of the following statements are false? Necrosis is a programmed cell death and causes cell shrinkage. Apoptosis results in nuclear swelling and lysis. Necrosis is energy dependent. Myocardial infarction is considered apoptosis. All of the above are false. Which is the correct answer? The answer is E. All the statements are false. Hope that the session was useful to you. The next session will be on molecular diagnostics. Goodbye from ACPGMet. Please visit the channel www.youtube.com/ACEPGMet. I am Dr. N.S. Mani, and the email inquiries can be made in acepgmet@gmail.com. Practice session on entrance test oriented MCQ also are available in the same channel and also from the Facebook. Thank you.